Uh, Now in this video we will discuss about the respiratory physiology. We are going to study about the respiratory physiology in four stages. First one is the ventilation. Ventilation includes two parts, the inspiration and expiration process. So how the air goes into the lung and how the air goes out of the lung, that is the process of ventilation. Okay, so that's the first process that we need to study. Then we have the gas exchange. Two levels of exchange we will study. The first level of exchange is between the lung and the blood, and the second one is the between the blood and the tissues. And in the between you have to see about the transport of these gases, oxygen, carbon dioxide, in the blood. That's with the help of the RBC and the plasma and the other substances. The blood is transporting the gases. So how this transport is happening? So these are the four processes. First we study the ventilation, then the gas exchange between the lung and the blood, and then the transport of the gases in the blood, and then fourth one is the exchange between the blood and the tissues. Okay, and once the oxygen and carbon dioxide is there in the cell, it undergoes the process of cellular respiration. So that is the process of utilization of the oxygen for the ATP production by the mitochondria and the production of carbon dioxide by various metabolic pathways. But this is mainly you study in your biochem. Okay, so the only these first four processes that we study now in our physiology. Okay, so let's first start with the ventilation. Okay, so what are the muscles used for ventilation? The process of ventilation includes inspiration and expiration. So first we will study about the muscles of inspiration. Mostly you will study the details of these, the nerve supply and the structure, etc., for in your anatomy. So basically it's the diaphragm that is contributing towards almost 100% of the inspiration in a quiet inspiration. Okay, in a quiet inspiration. Even in a forced inspiration, almost like 80 to 90% is contributed by the diaphragm. Diaphragm is a major part that contributes. Okay, the other muscles of inspiration other than the diaphragm includes the external intercostals. Okay, the external intercostals. So external intercostal is for inspiration and internal intercostal is for expiration. Internal intercostal for expiration, external intercostal for inspiration. Okay, so remember like that. The external intercostal is for the inspiration and it elevates the ribs. And in addition, there is the next muscle that take part after the diaphragm. And then you have the other muscles like the scalene and the sternocleidomastoid muscles on the neck and the anterior serratus are the accessory inspiratory muscles. Normally, the process of expiration is passive. You don't need any muscles involved over there. Normally, it's just the elastic recoiling and the surfactant and the surface tension that helps for the expiratory process. But in the case of forced expiration, you need the internal intercostals. Okay, that helps to depress the ribs. And then you have the abdominal muscles, the rectus abdominis, that compress the abdomen. When you compress, it helps to compress the lung. Okay, so these are the muscles of inspiration and expiration. Next thing is the reason for the air to move in is the pressure change. The air moves from high pressure to a low pressure. Okay, so in order for inspiration, in the atmospheric pressure should be high than the intrapulmonary pressure. Intrapulmonary pressure. Okay, so the atmospheric pressure is considered as like 760, and the intrapulmonary pressure for inspiration, if it is for the inspiration, it should be like around like 759. Then the air can flow from the atmosphere into the lung. And if it is expiration, during the process of expiration, the air should flow from here to here. So that means intrapulmonary pressure should be more than that of the atmospheric pressure. Okay, so then the exhale. Normally we don't use the atmospheric pressure like in, this is like represented in millimeters of mercury, but normally we say it in centimeters of water. Centimeters of water. Okay, so simply consider this as 0. So that means this 761 will be plus 1 and 759 will be minus 1. Okay, so that's the normal concept of using, like, 0 to plus 1 to and the plus 1 means the air will move from plus 1 towards the 0, so it means towards the atmosphere, and the vice versa. If it is minus 1 and if it is 0 here, it moves from 0 to minus 1 over here. Okay, so let's see over here. At the end of one respiration, after the expiration, the intrapulmonary pressure will be equal to 0. Okay, it's 0. That means it's 760 equals the atmospheric pressure, and there is no movement of the air. So it goes like here. You can see over here the graphical representation. That is like, so you put like 0 here, and like plus 1 over here, and minus 1 over here. So this minus 1, this is your inspiration up to 0. Okay, from this point to this point is inspiration, and from here to here is plus 1, that is your expiration. Expiration and inspiration. So that's how the inspiration and expiration happens. So during inspiration, the volume of pleural spaces increases, causing the pressure in the alveoli to decrease. Air then moves into the alveoli where the pressure is lower. Okay. At the end of the inspiration, alveolar pressure again equals to 0. That means atmospheric pressure, and there is no movement of the air. Okay. So this is one factor. Another factor that you need to look at is the intrapleural pressure. Okay, the intrapleural pressure, which is kept always negative. Intrapleural pressure means is the pressure between the parietal and the visceral pleura. There is a pleural fluid, and so if this is your lung, and surrounding that you have the pleura, that is the, so the fluid that is present in between this, okay, the parietal and the visceral pleura. So this is called as the intrapleural space. Okay, intrapleural. Okay, so this pressure is always negative. It ranges normally from say -2 to -5, etc. Okay, so it's always negative pressure. So during inspiration, what happens? It becomes more negative, and during expiration, it becomes less negative. Okay, so during inspiration, it becomes more negative, and during expiration, it becomes less negative. Okay, so that's what happens with the intrapleural pressure. So interpleural pressure is always slightly negative. At the beginning of the inspiration is about like -5, and by the end of the inspiration, due to expansion of the chest cages, more negative pressure of up to -7.5 or -8 centimeters of water is seen. Okay, so that's the intrapleural pressure. And during the inspiration, the volume of the air that comes in, okay, that is around like 500 ml, and during expiration, the volume of air is going out. This volume of air that goes out or goes in or goes out is called as the tidal volume. This is the tidal volume, and the normal volume of the normal value of the tidal volume is about 500 ml. Okay, so remember the volume 500 ml. Okay, and so now we have seen like inspiration, how the pressure changes happens, and also for the expiration to happen, we already mentioned that is a passive process. So how this passive process is taking place? What are the factors that controls the expiration? That is the collapse of the lung. Okay, it's for the expiration to happen. Okay, for the expiration to happen, you need the collapse of the lung to happen. So the lung have the tendency to collapse. Natural tendency is to collapse. Okay, so the elastic recoil caused by the elastic fibers in the interstitium of the lung. The interstitium contains a lot of elastic fibers, and these elastic fibers have the tendency to recoil and compress the lung or collapse the lung, and this helps for the expiration of the air. Okay, then another one is inside the alveoli. Inside the alveoli, there is a layer of fluids. Okay, layer of water. This layer of water will have a tendency to attract to each other, and this attraction between this water molecule is what is called as the surface tension. Okay, the surface tension is causing the collapse of the alveoli. So surface tension is causing, and the elastic recoiling, the elastic fibers is undergoing elastic. So these are the two factors that helps the lung to collapse, and thus causing the expiration as a passive process. So there is no muscle involved in these two things. Okay, so that is why it is a passive process, not requiring any energy. But we cannot allow the lung to collapse completely. we need to maintain it. Okay, so to expanded state we need to maintain. We cannot completely collapse. If it completely collapses, it becomes impossible for the muscles to work and bring it back to its expanded state. So we need to prevent the collapse of the lung. So what are the factors that prevent the collapse of the lung? Especially for the elastic fibers, what prevents it is the negative intrapleural pressure that prevents the elastic recoiling. Okay, so the negative intrapleural pressure does not allow the lung to completely collapse. And for the surface tension, what controls is the surfactant. Surfactant is produced by the type 2 alveolar cells. These are the stem cells that we have. Okay, the stem cells that is present in the alveoli, the type 2 alveolar cells, they produce surfactant. Okay, we'll study about the surfactant slightly later. So first let us discuss about the negative intrapleural pressure. In order to understand the importance of this negative intrapleural pressure, let us discuss one question over here. Okay, so in this question, a 22-year-old male is seen in the emergency department after being stabbed. Okay, he suffered numerous superficial laceration for his forearm, face with needle switches. However, he suffered a penetrating injury just above the fourth rib on the right side, making him dyspneic. He has a pleuritic chest pain as well. He has no known history and takes no medication. Vital signs are like 36-degree, blood pressure is little high, but not so, like the diastolic is low, and the heart rate is very high, 120. Respiration is high, with an oxygen saturation which is slightly less, like almost okay, but less than the normal, like which is around 90% on the room. He is pale, cool, and diaphoretic. There is a peripheral cyanosis. Peripheral cyanosis. That means there is lack of oxygen. Because of the lack of oxygen, he is awake and alert, breathing with very fast, very fast and shallow breaths. An oval puncture wound is seen on the anterior chest. Heart sounds are normal. There is no jugular venous distension. The trachea is midline. Okay. There is hyperresonance to percussion and distant lung sounds on the right chest. An X-ray reveals a pneumothorax. Here the question is directly giving you the diagnosis, that is the pneumothorax. Air within the pleural cavity compressing the right lung above 40% of its normal volume. Okay, so that's the vignette. Okay, so the vignette is trying to describe you a pneumothorax. So now the question is, which of the following changes during inspiration explains his breathing difficulty? Why is he having breathing difficulty? So what difficulty he is facing? He is facing a too much of collapse of the the lung. The lung is collapsed on the right side. Okay, so that is what we call it as the pneumothorax. Why this collapse has happened? Because of the stabbing. Because of the stabbing, the air has entered from the atmosphere into the intrapleural space between the two pleura, and this has abolished the negative intrapleural pressure. Because this has abolished the negative intrapleural pressure, so now the collapse of the alveoli or the collapse of the lung, okay, the elastic fibers, the elastic property of the lung is too much, so there will be too much of collapse. So in order to prevent the collapse of the lung, we have negative intrapleural pressure. This negative intrapleural pressure is lost in the case of a pneumothorax. So what will be the answer choice over here? Decreased intrapleural pressure. No, this is not the problem. Okay, the decreased intrapleural pressure is not the problem over here. So loss of elastic recoil, no, instead you have increase. It's not the loss, there is increased elastic recoil. Paralysis of the diaphragm, no, that's not the problem over here. Instead, equal intrapleural and atmospheric pressure, yes, that's the problem. Because of the stabbing, it has become equal to the atmospheric pressure, but what we actually want is not equal, instead a negative intrapleural pressure. So the negativity is lost and this become equal to that of the atmospheric pressure. So that's the problem. So diminished inspiratory volume because of pain, no, that is, pain is there, but the diminished inspiratory volume is not because of the pain. Okay, so can we use this one, the decreased intrapleural pressure over here? No, this is not correct, because it's not decreased. Okay, the intrapleural pressure is already like negative. It has increased and become equal to the atmospheric pressure over here. It has become increased and become equal to the atmospheric pressure. So that is what happens in this question. Okay, so hope you have understood the importance of the negative intrapleural pressure. Now let us discuss about the surfactant and the importance of the surfactant. Okay, so the surfactant is a complex that is produced by the type 2 alveolar epithelial cells. Okay, secreted by the special cells called as type 2 alveolar epithelial cells. There are other cells like Clara cells, club cells, etc., but those are not seen in the alveoli. Those also produces surfactant like products like mucus, etc., in the pathways, okay, in the bronchioles, etc. But inside the alveoli, it's the type 2 alveolar cells that produces the surfactant. Okay, surfactant is a complex mixture of phospholipids, which includes the phospholipid. The name of the most important phospholipid is the dipalmitoyl phosphatidylcholine. Okay, so this along with calcium, which is used for the saponification process, is mainly the component. But there is other component that is required, that is the surfactant proteins or the surfactant apoproteins, which is named as A, B, C, D, etc. These proteins help for the spreading of the surfactant. Spreading of the surfactant is very important. Okay, so the spreading is caused by these surfactant proteins. Okay, so now let us see the importance of the surfactant with the help of the Young Laplace law. Okay, which states the pressure in the alveoli is equal to 2 times the surface tension divided by the R. So this is the Laplace law. Okay, so that means if the radius is more, the pressure will be less. So if you take this big alveoli and the small alveoli, here the radius is more, so the pressure will be less, and here the radius is low, so the pressure will be high. So here there will be high pressure, and this here will be low pressure. So if you connect these two, if there is a connection between these two, what will happen? From a high pressure to a low pressure, the air will move. Okay, and this will collapse and this will become bigger. So we don't want that to happen in our body. Okay, we don't want that to happen in our body. We want, anatomically there are different shapes and sizes for the alveoli, so we want to maintain them. So how to equalize the pressure in this big alveoli and the small alveoli? That is not by controlling the radius, but by controlling the surface tension. Okay, so in the big alveoli and compared to the small alveoli, here the pressure is low. Okay, and here the pressure is high. So the aim is to change this pressure, to increase the pressure over here, and here the aim is to decrease the pressure. So in order to do that, what should we do to the surface tension? Here, if you want to increase, you want to increase the tension, the surface tension. In order to increase the surface tension is normally prevented by the surfactant. You reduce the surfactant. Okay, you reduce the surfactant. Actually, by reducing the surfactant, it means what? Increase the spread of the surfactant. Increase the spread of surfactant. Increase the spread. So if you spread it far away, what will happen? There will be decrease in surfactant, there will be increase in tension, there will be increase in pressure. But in this alveoli, what is then? You want to convert the increased pressure to decreased pressure. In order to decrease the pressure, what we want to do? Decrease the tension. In order to decrease the tension, you want to increase the surfactant. That means there will be closely spread. The surfactant will be very closely arranged. Okay, closely arranged in the small. Okay, so this arrangement is mainly the spread of the surfactant, and the closely arrangement of the surfactant is mainly caused by the surfactant protein. Okay, the surfactant protein A, B, C, D, those ones. Okay, so that is what is being shown by this equation over here. Okay, so here the tension is 1 and the radius is 1. Okay, so here the pressure is 1 and the pressure is 2 over here, but you want to change that to equal. Okay, to equal. So you want to reduce this. How to reduce this? By increasing. So this 2 has to be reduced to 1 here. So how do you reduce it? By reducing the tension. How to reduce the tension? By increasing the surfactant. Okay, so there are disease conditions in which you don't have surfactant. If you don't have surfactant, what will happen? There will be collapse of this alveoli. The collapse of the alveoli will happen. The smaller alveoli will be collapsing. That process of collapse is called as what? Atelectasis. Okay, atelectasis. Okay, normally seen in disease condition like respiratory distress syndrome. Like you can see it in the newborns or in the infant respiratory distress syndrome, or like the acute respiratory distress syndrome. Okay, so what happens over here, the type 2 pneumocytes are not fully developed in the infants, and especially seen in the preemies or the early born. When the child is born early before the maturation has attained, then we call it as the preemies. In the preemies you can see this neonatal respiratory distress syndrome or the infant respiratory distress syndrome, caused by the lack of the development of the pneumocytes. So what will happen to the pneumocytes? Pneumocyte, that is the type 2 pneumocyte, is not mature. It's not mature, so there is no surfactant. So because of there is lack of surfactant, the water molecules will show more surface tension, and this will show the collapse of the alveoli. Okay, so that is what happened. And what is the name of this disease condition? The infant respiratory or respiratory distress syndrome, in histologically it is called as a hyaline membrane disease. Hyaline membrane disease, because in the microscopic image you will see this hyaline like appearance. Because of the collapse of the water molecules, the water molecules will appear, and when you take the cross section, that water molecule will give like a glassy appearance of this water level. So this looks like a hyaline. So that's why it is referred to as a hyaline membrane disease. Okay, now we start about the discussion about the compliance of lungs. Okay, compliance is the opposite of elasticity. Elasticity. So the actual definition of elasticity is the ability of a substance to resist the change in its shape. So if I take three substances, for example, if I use a balloon, balloon, a plastic bag, and a steel ball. In these three things, we have to see what is the elasticity, okay, and which one is compliance. Okay, compliance. So compliance means the ability to stretch. So the compliance is highest for the plastic bag. The compliance is highest for the plastic bag. The plastic bag. So that means it is easy to expand. It's easy to expand. So if you just try to blow the plastic bag, it will expand very easily compared to a balloon or a steel ball. Whereas the elasticity is highest for the steel ball. That means it resists the change in its shape. It cannot expand. So if you try to blow it and try to change its shape, it cannot change. Okay, so in the case of a balloon, it's compliant as well as elastic. It's in the middle of these two. Okay, so that means our lung all normally behave like that of a balloon. It have like partial elasticity and it have like partial compliance. It is expandable and it also resists the change in the shape. Okay, so it's in the middle of it. So we need such a lung which is like a balloon, which can be expanded but does not like act like a plastic bag. That means if our lung is acting like a plastic bag, that means if it have a very high compliance, that means it will expand very far, very much, and cannot be compressed. That example of a disease condition like that is the emphysema. Emphys Emphysema. Okay, in emphysema, what happens? The elastic fibers are lost. A smoker, when they smoke, these neutrophils will produce and elastase that breaks down the elastic fibers. Okay, or trypsin, like kind of enzymes which are degrading the proteins. The elastic fibers are broken down, so the elastic fibers are lost in that condition. So what will happen to the lung behaves like a plastic bag and it will remain expanded. Okay, so that's what happens in conditions like emphysema. Whereas in conditions like um, fibrosis, where you have increased elasticity, okay, like conditions like fibrosis. So what happens in fibrosis? For example, if a person is working in a coal mine or something like that, this coal particle will fall in the lung, and then the lung connective tissues will start to produce fibrous tissue. This is in the interstitium of the lung, and this fibrosis will make it like a hard lung. And it's not easy to expand. Okay, so it becomes difficult to expand, difficult to expand, expand. Okay, so that happens like in a steel ball. So that is what happens in the fibrous. If the lung becomes fibrous, it becomes difficult to expand. So conditions in which it is difficult to expire. Okay, here the problem is it's easy to expand. Okay, elastic fibers are lost, so here it is difficult to expire. Expiration is difficult to expiration. This condition is referred to as the obstructive conditions. Okay, this condition is referred to as the obstructive lung disorders. Obstructive. Okay, whereas difficulty to expand, or that difficult to expand, that means difficult to inspire. Okay, expanding is required for the inspire. So difficulty in inspiration will cause what is referred to as the restrictive lung disorders. Okay, restrictive lung disorder. Okay, so this is the two classification of the various lung disorders that we have. Okay, so with this introduction, let us see what is the compliance of the lung. So the lung compliance is the extent to which the lungs will expand for each unit increase in the transpulmonary pressure. It may be the transpulmonary pressure, that is the pressure, or the otherwise referred to as the transmural pressure, that is the pressure difference between the alveolar pressure and the pleural pressure. So but sometimes the books may use just the pleural pressure itself. Okay, the negative intrapleural pressure itself to represent the compliance. Okay, so this is just by the delta V, that is change in volume divided by change in pressure. Okay, so that is your compliance. But elasticity means what? It is change in pressure over change in volume. Okay, so this is elasticity. So change in volume by change in pressure is the compliance. Okay, so the greater the compliance, the easier it is for expansion of the lung. So conditions like emphysema, normal aging, fluid filled lung, etc. will cause what? Increased compliance. All these conditions is causing increased compliance. And a lower than normal compliance means that it is harder to expand the lungs. Condition like fibrosis, acute respiratory distress syndrome, which also includes the atelectasis, pneumonia, pulmonary edema. Okay, so here the fluid filled inside the lung, in the example is like a here the condition is like drowning. Fluid filled in the interstitium, that is your pulmonary edema. Okay, pulmonary edema is difficult to expand, but when the fluid is inside the lung, it's easy to expand. So here you have decreased compliance. Okay, the compliance is decreased over here. Okay, so now let us see how this compliance is represented on a graphical manner. The delta V by delta P, how do we represent that in the graph? Okay, so we take in the graph, here you have the volume and the pressure. Okay, change in volume over the change in pressure. So this is normally how the, so as the pressure is, the change in pressure increases, there will be increase in the volume of the lung. Okay, so this is the normal compliance. Okay, so when we shift this line on to the left or to upward, then that means there is increased compliance. If we shift it to down, like down, or to the right, this means there is decreased compliance. So that is the meaning of the graphical representation. Okay, so over here you can see if this is the normal. Okay, so this part is the normal range. Okay, here this is the normal. So if you are shifting to the left or towards up, that means there is increased in the compliance, that is like emphysema. If it is shifted to the down or to like right, okay, then it is fibrosis or conditions where there is decreased compliance. So this is a graphical representation, but sometimes we don't represent it like as a single line because of the inspiration and expiration. Okay, over here you can see inspiration and expiration, which is creating a hysteresis loop over here. This loop that is created between the inspiration and expiration is called as a hysteresis loop. By looking at this, you can see during inspiration you have decreased compliance because already the lung is expanded. There is no much further expandability for the lung. So that is why during inspiration the compliance is less, and during expiration the lung have increased compliance. That is one reason, because of the inspiration and expiration. And the reason is because during inspiration the surfactants are spreaded far away and there is more surface tension. so its expandability is reduced and it have a more tendency to collapse. Okay, so that is why there is decreased in this one. Whereas during expiration, the surfactant molecules are coming close to each other and the surface tension is being removed. So that is why there is more compliance, easy to expand in the case of expiration, the smaller lung. Okay, so that is why there is a difference between the inspiration and expiration. So you inspire and then you expire. So inspiration and then expiration. So inspiration less compliance, expiration more compliance, and that's why you get a hysteresis loop. But the reason for that is a surfactant. Okay, the surfactant brings this difference in the property, and the surfactant is changing the surface tension. But if you think of a lung which is like fluid filled, there is no surface tension because there is no interaction between the two, because it's fully filled with water molecules. So there is no interaction between the water molecules, like attraction between the water molecules. Like if there is air in between the water molecules, they will attract. So that is called a surface tension. Here there is no surface tension if the fluid is filled inside, the saline filled. So what happens? The whole thing will shift. So here, so there will be increased compliance when there is the fluid is filled inside the lung. Not only that, the hysteresis loop that you see over here is completely disappeared. No hysteresis loop over here. That means there is no difference between the inspiration and the expiration compliance. It becomes equal. So that difference between the inspiration and the expiration compliance is brought by the factor of surface tension, which is eliminated when the lung is filled with water. Hope you understood that. Okay, so these are the major important points that you must remember about the compliance. What happens to the compliance in different disease conditions? Like these are the obstructive lung disorders, obstructive, and this is the restrictive lung disorders. Okay, restrictive lung disorders. So we normally refer as the OLD, obstructive lung disorder, and restrictive lung disorder, RLD, restrictive lung disorder. So in the restrictive lung disorder, the compliance decreases, and in obstructive lung disorder the compliance is increased, easy to expand. Okay, so that's about the compliance. And then now let us see the that was the compliance of the lung. Now let us see the compliance of the chest wall and how it is being compared to that of the lung. Okay, so there is a tendency for lungs to collapse inward, whereas there is chest wall likes to spring outward, it goes outward. Okay, so at FRC means the functional residual capacity. Over here this line represents the functional residual capacity. So the volume of air that is present below that, this is the functional residual capacity. So that means the volume of air that remains in the lung during the tidal inspiration and expiration. Okay, after the tidal expiration, what is the amount of air that remains in the lung is called as the functional residual capacity. Okay, at FRC, inward pull of the lung is balanced outward pull, balanced by the outward pull of the chest wall. Okay, and the system pressure is atmospheric. Okay, so the elastic properties of both chest wall and lungs determine their combined volume. So at FRC, airway and alveolar pressures are zero, and the intrapleural pressure is negative, and this prevents the pneumothorax. So over here, this line represents the the combined compliance. Okay, and this area is the work done by the lung in order to create that inspiration or the tidal volume. Okay, and let me take another one. Okay, so this area that is represented over here, okay, like A, this area represents the work, the elastic functioning of the lung, and this area that is present over here represents, this area that is present over here represents the functioning of the chest wall. Okay, the chest wall functioning. So chest wall is opposing the action of the lung, so they are getting cancelled each other. So the elastic energy lost from the thorax is equal to that gained by the lung. So this area that is represented over here is equal to this area. Okay, so just like it is helping each other, and that is why the lung falls in the middle of it. Okay, now let us look at the another concept, that is the resistance to breathing. Okay, so alveoli doesn't have any smooth muscles, so the resistance to breathing is brought by the bronchioles, the smooth muscles. Okay, especially the smooth muscles. So the greatest amount of resistance occur in larger bronchioles than in terminal bronchioles. In disease conditions, airflow resistance increase by smooth muscle contraction in smaller bronchioles. Okay, edema occurs in the walls and mucus collecting the lumens of the bronchioles. Sympathetic, okay, sympathetic stimulation, that is by the epinephrine and norepinephrine, cause dilation of bronchial tree through the beta 2 receptors. Parasympathetic, that is through the vagus, acetylcholine through the muscarinic 3 receptor, causes constriction of the bronchioles. In addition to this, the alveolar mast cells release bronchiole constrictors, histamine, and the slow reactive substance of anaphylaxis during allergic reaction, and one of the reason for asthma. Okay, and parasympathetic, increased vagal output can also cause what? Can cause asthma. Okay, so now our next topic is pulmonary volumes and capacities. Okay, in order to do the pulmonary volumes and capacities, we use this parameter. Okay, so it actually gives you the pulmonary function test. We call it as the PFT, pulmonary function test. Okay, so pulmonary volumes are the volume of air that is present in a single concept. Okay, it's like tidal volume, but capacities means sum of one or two more volumes together is what is being referred to as the capacities. So we have like different volumes like tidal volume, inspiratory reserve volume, expiratory reserve volume, and the residual volume. These are all the volumes. Then the sum of these will give you the capacity. We have the inspiratory capacity, functional residual capacity, vital capacity, and the total lung capacity. Let's see using this graphical representation over here. What are the pulmonary volumes and the capacities? Okay. Okay. So the first one is the tidal volume. The tidal volume is over here. Okay. So it's the volume of air. This is the tidal volume, which is normal value is around 500 ml. 500 ml. So this is the volume of air that you can normal in a person when a person is normally breathing in or out. Okay. So the air volume of air that can be breathed out or breathed in a normal inspiration or expiration is called as tidal volume. Okay. The volume of air that remains in the lung after the tidal expiration from this point to this point, okay, is called as the functional residual capacity. And this is the functional residual capacity. That is the normal volume of air that remains in the lung, which is around like 2.4 liters, okay, 2.2, 2.3, like that's the normal range in which you will see the functional residual capacity. Functional residual capacity, when you say the capacity, it includes two volumes, which are the residual volume and the expiratory reserve volume. Expiratory reserve volume is the volume of air that can be expired out from here to here, expired out forcefully after the tidal expiration. After the tidal expiration, the volume of air that can be expired out forcefully is called as the expiratory reserve volume. And the residual volume is the volume of air that remains in the lung after the forceful expiration, that is called as the residual volume. Okay, this is the volume that never goes out. So it's approximately like around like 1200 ml. Okay, around like 1200 ml is the normal volume of residual volume. So residual volume plus expiratory reserve volume will give you functional residual capacity. Functional residual capacity is residual volume plus expiratory reserve volume. This is your functional residual capacity. Now another thing is the vital capacity. Vital capacity is the volume of air that can be forcefully expired out after the forceful inspiration. After the forceful inspiration, the volume of air that is expired out. We always take the vital capacity as the volume of air that can be forcefully expired out, not the volume of air that can be forcefully inspired in, because that does not gives an indication during the distinguishing for obstructive versus restrictive lung disorder. That's the reason that why we don't use them, the inspired volume. Instead we are using the expired volume, the forcefully expired volume after the forceful inspiration. After the forceful inspiration, you can the volume of air that is expired out forcefully is called as the vital capacity. Vital capacity includes three volumes, okay, which are the inspiratory reserve volume plus tidal volume plus expiratory reserve volume. All the three sum of these three is called as vital capacity. So what is in expiratory reserve volume and tidal volume we have discussed. Inspiratory reserve volume is the volume of air that can be inspired in forcefully after the tidal inspiration. After the tidal inspiration, from this point to this point, to here to here. So after the tidal inspiration, the volume of air that can be inspired in forcefully is called as the inspiratory reserve volume. So vital capacity equal to inspiratory reserve volume plus tidal volume plus expiratory reserve volume. Okay, all these three sum is called as the vital capacity. Okay, now another thing is the inspiratory capacity. Inspiratory capacity is the inspiratory reserve volume plus tidal volume. Okay, so if you want to define that, it is the volume of air that can be forcefully inspired in after the tidal expiration from this point up to here, this point. From this point to this point is the tidal inspiratory reserve volume, and after the tidal expiration from here, the volume of air that can be forcefully inspired in after the tidal expiration is called as the inspiratory capacity. Inspiratory capacity is the inspiratory reserve volume plus tidal volume. So vital capacity can also be calculated as inspiratory capacity plus expiratory reserve volume, because inspiratory reserve volume plus tidal volume is inspiratory capacity. So inspiratory capacity plus expiratory reserve volume will give you vital capacity. So total capacity, total lung capacity is the sum of all the four volumes together. Inspiratory reserve volume plus tidal volume plus expiratory reserve volume plus residual volume. All the four added together is called as total lung capacity. Or these two together is called as what? Inspiratory capacity. Inspiratory capacity plus expiratory reserve volume plus residual volume is called as what? The FRC, functional residual capacity. So sum of inspiratory capacity plus functional residual capacity is also equal to total lung capacity. Okay, so the questions may be asked in a different way for you to calculate. So make sure you have this image of this graph in your mind, and so that will become easy for you to calculate these values. Okay, so now normally we use these pulmonary volumes and capacity for calculation of the for the distinguishing for the pulmonary function test to distinguish between obstructive lung disorders versus restrictive lung disorders. So let's see what happens in those. Okay, and one of the important values, the volume that cannot be calculated using the spirometry is the residual volume. The residual volume cannot be calculated. Okay, cannot be calculated in spirometry. So instead you have to use the helium dilution method. Okay, helium dilution method for that calculation. So anything that includes the residual volume cannot be calculated. For example, this includes residual volume. So can we calculate the total lung capacity using the spirometry? No. Okay, same way the functional residual capacity includes the residual volume. So can we calculate the functional residual capacity using the spirometry? No. So but when you add the helium dilution method to the spirometry, then we can calculate all of them. Okay, so without the helium dilution method, the only thing that we can calculate is the vital capacity. The major thing that can be calculated is the vital capacity, which includes the inspiratory reserve volume, tidal volume, expiratory reserve volume. So these are the three volumes that you can calculate: inspiratory reserve volume, tidal volume, expiratory reserve volume. And inspiratory reserve volume plus tidal volume, they will give you inspiratory capacity. So you can calculate inspiratory capacity, you can calculate vital capacity. Okay, so other than that, the total lung capacity cannot be calculated, functional residual capacity cannot be calculated, residual volume cannot be calculated. So those things cannot be calculated using the spirometry alone. So you need to combine the helium dilution method to the spirometry. So now let us see how we can use them for the distinguishing factor between the obstructive lung disorder versus restrictive. So dynamic lung volumes and capacities are taken. We use the dynamics in which the patient is advised to do all this process, the expiration or inspiration, as fast as possible. So time factor is important. Okay, so in order to represent the dynamic, we, instead of calling it as vital capacity, we call it as forced vital capacity, which is abbreviated as FVC. Okay, so that now we have included the time factor. So in order to represent the time factor, we say forced expiratory volume in the first 1 second, forced expiratory volume in the second, second, in 2 seconds, like that. So FEV1, FEV2, etc. But FEV2, etc. is not so relevant. The most relevant one is the in the first 1 second, how much the air that is expired out. Okay, so forced vital capacity and the FEV1, these are very two important parameters to distinguish between obstructive lung disorders and the restrictive lung disorder. So what happens over here, you can see this is the normal person. Okay, in a healthy normal adult male, FVC is approximately 4 to 5 liters, FEV1 is approximately 4 liter, and thus the calculated FEV1 by FVC is about 80%. That is what is shown in this graph, the normal one. Okay, so you can see in 1 second, up to here. So this is like the volume of air that is expired out in 1 second. 1, 2, 3. Okay, 3 over here, and then over here is the total, the vital capacity is like 1 0 to 4, 1 2 3 4. Okay, so that is what is giving you FEV1 by FVC or of around 80%. Okay, so whereas in conditions like obstructive lung disorder, like airway obstruction, like chronic bronchitis, or in emphysema, etc., what happens, the time taken for the expiration becomes long. Okay, it becomes very long. Okay, so the FEV1 in the 1 second is very low. Okay, and not only that, the total the FVC is also low. Okay, so obstructive disorders results in a marked decrease in both FVC and the FEV1 by FVC ratio, whereas the restrictive disorders result in a loss of FVC without a loss in FEV1 by FVC ratio. Okay, let me show you in a different graphical representation over here. Over here, you can see the FEV1 by FVC ratio is reduced to around 40% from the normal. So this is what happens in the obstructive lung disorder. So that is the major component. Okay, so normal FEV1 by FVC is 80%. In obstructive, FEV1 by FVC ratio will be decreased less than 80%, and in restrictive it will be equal to 80 or like slightly more than 80 also. Okay, so what happens over here in the obstructive lung disorder, your total lung capacity is more. You can see the total lung capacity is increased than the normal. Okay, because there is volume of air remaining over here, because the residual volume is increased. Because the residual volume is increased, what happens, the functional residual capacity is also increased. Because of the increase in residual volume and the functional residual capacity, what happens, the total lung capacity is also increased. But what happens to the FVC? Decrease. FEV1 decrease. And what happens to the ratio? The ratio is decreased. So total lung capacity increase, residual volume increase, functional residual capacity increase, but FVC, FEV1 and FEV1 by FVC ratio decreases in the case of obstructive lung disorder. In the case of restrictive lung disorder, what happens? The total lung capacity, okay, is decreased. Residual volume is decreased. Functional residual capacity is decreased. Okay, and FVC is decreased. FEV1 is decreased. All of them are decreased. But what happens to FEV1 by FVC ratio? It stays the same. Okay, it does not decrease. FEV1 by FVC ratio does not decrease. Sometimes it may show slight increase also, but the mainly you can keep it in mind that it does not decrease. Okay, so I hope you have understood how to use this spirometry, the values and the graphical representation for understanding the distinguishing factor between obstructive versus restrictive lung disorder. In order to understand that, let's do one question over here. Okay, here in this question, a 55-year-old male present with several weeks of progressive dyspnea. Ever since his diagnosis of atrial fibrillation with a rapid ventricular response 10 years ago, he has slowed down his life significantly. He was successfully cardioverted into sinus rhythm at the time of diagnosis, and since then he has been on amiodarone, a drug which you will study later on in your pharmacology, for rhythm control, and has not seen or felt the atrial fibrillation again. Over the past few months, his course has become much more difficult to complete. In recent weeks, he has lost the ability to exercise at all. It was a slow but steady progression, and now that it affects him daily, he is seeking evaluation. Vital signs are normal, blood pressure normal, heart rate is okay, respiration rate is okay, oxygen saturation is also okay. The physical examination is significant for inspiratory crackles over the lung bases. The rest of the exam is normal. A chest radiograph demonstrates reticular markings in all lung fields, and echocardiogram shows normal ejection fraction. Okay, and also the question is directly giving you long-term amiodarone use carries the risk of pulmonary fibrosis. So patient have using amiodarone, and this amiodarone use is causing what? Pulmonary fibrosis. This is the key for you. So to evaluate pulmonary function test is ordered. So now which of the following is most likely to be expected on the pulmonary function test. So fibrosis is what kind of a condition? It is a restrictive lung disorder. Restrictive lung disorder. So in restrictive lung disorder, let's see the options. What happens to FEV1 and FVC? It has to be decreased. Okay, in both obstructive lung disorders and restrictive lung disorder, both FVC will be decreased and FEV1 will be decreased. But what happens in the restrictive lung disorder to the FEV1 by FVC ratio? It's equal to 80 percentage. Okay, it does not decrease. Okay, it does not decrease, it will remain like this. But the answer choice does not have this one. It has asking you only about these two, FVC and FEV1. So FEV1 has to be decreased here, not no change. So FEV1 is decreased over here, FVC is decreased. So this is your answer choice. No change, no change, no change. No. So this is your correct answer. Okay, good. Hope you have understood how to utilize this information to answer some questions. Okay, topic is alveolar ventilation. So what is alveolar ventilation and how is it different from minute ventilation? So let me talk to you about like the minute ventilation. Minute ventilation is the tidal volume multiplied by respiratory rate. That means in 1 minute how much amount of air is coming into the lung. So that is the minute ventilation. So which is normally equal to like tidal volume say 500 ml. Say approximately respiratory rate is equal to 12, which is around 6000 ml. Okay, now what is alveolar ventilation? Out of this tidal volume, how much is the volume of air that is reaching to the alveoli? In order to understand that, we have to understand all the air that you inspire in is not reaching to the alveoli. Some of them is staying back in the respiratory tract. Okay, so that air is called as the dead space air. Okay, so that air that does not reaches okay into the air reaches into the gas exchange area, which includes the alveolar sacs, alveolar ducts, and the respiratory bronchioles. Okay, so it's called as alveolar ventilation. The amount of inspire that is available for gas exchange. Okay, so the remaining is there in the physiological dead space, which includes the nasal spaces, nasopharynx, trachea, bronchioles, all those. Okay, so normally, so alveolar ventilation is equal to tidal volume minus the dead space. Then you have to multiply that with the respiratory rate. So that becomes in a minute. So normal amount of dead space is around like 150 ml. In a normal anatomical dead space is 150 ml. So tidal volume is around 500 ml. So 500 minus is equal to respiratory rate. Say let's take it as 12. So is equal to, and this will come around like 4200 ml. So you can see out of like 6000 ml that is you are taking in, only 4200 ml is actually used for the alveolar ventilation. That is the one that is used for the exchange of the gases with the blood. Okay, so now there are different types of dead space. You have physiological dead space. This 150 that we have told is the anatomical dead space. For example, anatomical dead space can also be increased when you connect a tube, or like for example when a person is doing snorkeling, the tube that you connect to your nose, so that whole area is also considered as a dead space air in the tube is also. So that is the anatomical. But physiological dead space means what? Anatomical dead space plus any of the alveoli that is like relaxing or not, like the blood supply is not going there or not being used, is called also a physiological dead space. Pathological dead space means what? The dead space that includes damaged alveoli or damaged the blood supply is not going to that region. So those areas where there is no exchange happening, that is called as the pathological dead space. So anatomical dead space is the least one. Physiological dead space includes anatomical plus extra, and pathological also anatomical plus extra that is there. Okay, so always anatomical dead space is less compared to that of the physiological and the pathological dead space. Okay, so another concept that I would like to say about here is the rate. Okay, and changing the rate and the depth of the ventilation. What happens to minute ventilation and the alveolar ventilation? For example, instead of like in respiratory rate, you change it to 24. Okay, doubling it, and instead of 500 you are taking only like say 250 ml. So that means the person is breathing fast but shallow. Okay, shallow breathing. So how much is the minute ventilation? Again, it is the same 6000 ml. There is no change over here. Okay, even though you changed it, it remains the same. But that's not the case with the alveolar ventilation. Alveolar ventilation will, instead of this like 500 is 250. There's no change in the dead space, so it is 150 multiplied by 24. So how much it will become? Say it is like 100 multiplied by 24, it's like 2400 ml. Even though, see over here it is like 4200, here you have only 2400 ml that is coming in, because the person has changed the ventilation to fast, rapid and shallow breathing. So the alveolar ventilation has decreased a lot compared to, whereas the minute ventilation remains the same. Instead of this, if a person is breathing slowly, like say instead of 12 times, he's breathing only 6 times, and then instead of like 500 ml, like the person is inspiring around like 1000 ml, he doubled the tidal volume and decreased the respiratory rate. Still, what happens? The minute ventilation remains the same. It's the same. But what happens to the alveolar ventilation over here? The tidal volume is 1000 minus 150 multiplied by 12. Okay, so here it will be like around like 850 multiplied by 12, which is around like 5000 ml. Okay, so you can see there is an increase in the alveolar ventilation. All these three cases, what happened to the minute ventilation? It stayed the same. So when the person is breathing slow and deep breathing, what is happening to the alveolar ventilation? It is increasing. Instead, when a person is breathing fast and shallow, what is happening to the alveolar ventilation? It is decreasing, and too much of decrease. So slow and deep breath will help to increase the alveolar ventilation. And as far as the patient is concerned, the alveolar ventilation is more important, because alveolar ventilation is the one that is used for the exchange. Okay, so now comes the important concept of the dead space. The dead space. Okay, how much is the dead space in a person? So even though I have mentioned to you that 150 is the normal, this is the 150 ml is the normal dead space in a, say in a 70 kg man, it changes from person to person. So we need to have an equation to calculate the dead space. Okay, so that equation is given by the Bose equation to calculate the dead space. Okay, even though it has been like mentioned over here how it is being derived, we are not so much interested to know the derivation of this equation. Just like memorization of this equation is sufficient for you, just like understand the equation. So there is a mnemonic that is given to memorize this equation. We call like, so dead space is equal to tidal volume multiplied by partial pressure of carbon dioxide in the arterial blood minus the partial pressure of carbon dioxide in the expired air. Okay, so this is the tidal volume. There is the partial pressure of oxygen in the arterial blood, partial pressure of carbon dioxide in the expired air, and partial pressure of carbon dioxide in the arterial blood. So we call this as TACO, that is the tidal volume, and then PACO, PICO, and PACO. Okay, so that gives an a mnemonic like taco, paco, pico, paco. So just to understand what are these words, okay, just to give a rhyming words over here to memorize it. Okay, not only that, you need to memorize the normal values. So most of the cases the question will give you these values, you have to just put it in this equation and calculate the dead space. Okay, so normal value of tidal volume is like 500 ml. Okay, 500 ml. And PACO, arterial carbon dioxide, is 40 mm of Hg, 40 mm of Hg, and PICO is 28. Okay, PICO is 28 mm of Hg, and PACO is again 40. Okay, so this TACO, PACO, PICO, PACO. So 540, 28, 40. So these are the normal values that you need to memorize it for here. And then normally if the question gives you these values, then you can put them here and calculate the dead space. The purpose of calculating the dead space is mainly to calculate the alveolar ventilation. Okay, so alveolar ventilation is important. What is the purpose of like calculating the alveolar ventilation? Is to put it in like the equation of alveolar ventilation by perfusion ratio. Okay, this ratio is very important to distinguish various pulmonary disease conditions. We are going to discuss that now. V by Q ratio. So before going to V by Q ratio, we will discuss about the perfusion. Okay, perfusion means the blood that is going to the lung, that is the pulmonary circulation. Okay, so the pulmonary circulation. So the lung receives two types of circulatory systems to the lung. Okay, that is the high pressure low flow circulation that supplies systemic arterial blood supply mostly by the bronchial arteries. So you have the normal systemic circulation that is going to the lung. In addition to that, you have the pulmonary circulation, which is a low pressure but high compliance and high flow circulation that supplies the venous blood to the alveolar capillaries, where oxygenation is added to the carbon dioxide removed. Okay. Okay, so the pulmonary capillary pressure is otherwise referred to as the pulmonary wedge pressure, which we have studied in the cardiovascular system. Okay, the pulmonary wedge pressure, which is equal to the left atrial pressure. Okay, which is an equivalent measure. So a difference of approximately 5 is there for the left atrial pressure versus the pulmonary wedge pressure. That's the pulmonary capillary pressure. And in the pulmonary arterial system, there is a range of the pressure which ranges around like 8 to around 25. That's diastolic versus systolic, and the mean pressure in the pulmonary is about 15. Okay, so the blood volume of the lung is about 450 ml, which is about 9% of the total blood volume. So lung serves as the blood reservoir. Okay, some of the cardiac pathology may shift the blood from the systemic circulation to the pulmonary circulation. Okay, there will be too much of blood accumulating in the pulmonary. For example, failure of the left side of the heart, mitral stenosis or regurgitation, etc., will cause accumulation of the blood in the pulmonary system. And what happens with that? You get pulmonary edema because of that. Okay, you can get pulmonary edema because of this accumulation. Okay, so another very important concept for the exam is decreased alveolar oxygen reduces local alveolar blood flow by causing vasoconstriction and regulates pulmonary blood flow distribution. Okay, so decreased oxygen in alveoli cause what? Cause vasoconstriction. Okay, cause vasoconstriction. So this is not true in the case of systemic circulation. This is true only in pulmonary circulation. This is true only in pulmonary. In systemic, what happens? Hypoxia, that means lack of oxygen to the tissues, will cause what? Vasodilation. Will cause vasodilation, because this makes sense, because when the tissue is not having oxygen, you need to vasodilate and supply oxygen, whereas when there is no oxygen in the alveoli, you don't need the blood to go there, because there is no oxygen, there is no need for the blood to go there. So what happens? The blood vessels undergo vasoconstriction. Okay, so this is an important concept for an exam point of view also. In the pulmonary, it causes lack of oxygen causes vasoconstriction. In the systemic, lack of oxygen or the hypoxia causes vasodilation. Okay, so now let's continue about the pulmonary blood flow, and let's look more details of the ventilation perfusion ratio. Okay, so in the lung, we normally discuss with the effects of the hydrostatic pressure on the pulmonary blood flow. Okay, there are different factors that controls the blood flow. In order to understand these factors, we divide the lung into zones: zone 1, 2, 3 of the pulmonary blood flow. Okay, this may not be like always true that your lung have these zones. No, need not. Okay, so zone 1 means what? No blood flow during all portions of the cardiac cycle. This zone 1 is not normally seen. In case if it is seen, it will be seen towards the apex. Okay, apex have a high chance to get zone 1. Okay, and zone 2 is seen when there is intermittent blood flow only during peaks of the pulmonary arterial pressure. That means during the systole there will be blood flow, and during the diastole there is no blood flow. And zone 3, continuous blood flow, because the alveolar capillary pressure is greater than that of the alveolar air pressure during the entire cardiac cycle. Okay, that's normally seen in the base. Okay, this is the middle of the lung. Okay, so what happens over here? The zone 1, the alveoli are big. There is a big alveoli, and the alveolar pressure is more than that. So in the zone 1, there is no blood supply happening because of that. Okay, in zone 2, only during systole you get the blood supply. Okay, and during in the zone 3, the alveolar is very small, the alveolar pressure is always less. So what happens? You get always the blood supply during systole, and during diastole you get the blood supply. Okay, so another concept that we need to know about, like the ventilation and the perfusion in the apex, is that the ventilation is less than that of the perfusion. Okay, perfusion is very here. So what happens to ventilation perfusion ratio? It is high. Okay, here the ventilation is more, uh, perfusion is more than that of the ventilation here. Both the ventilation and perfusion is more here, but perfusion is more than that of the ventilation. So what happens to ventilation perfusion ratio? There's a decreased ventilation perfusion ratio here. Okay, and with exercise, what happens? There will be increased cardiac output, and there is vasodilation of the apical capillaries, and resulting in a V by Q ratio approaches 1. Okay, so the normal V by Q ratio, ventilation perfusion ratio, is about zero point 0.8. How we get this 0.8? Ventilation, normally alveolar ventilation we have seen, that is 4200 ml, 4.2, and the perfusion is the normal cardiac output, which is 5, which is equal to 0.8. But the ideal V by Q ratio, it should be equal to 1. That means we want equal ventilation and equal perfusion. That is the ideal. And during exercise, because of these phenomena, you can see the ideal ventilation perfusion ratio. During rest, you will see this ventilation perfusion ratio of 0.8. Okay, so let's discuss more about this change in the ventilation perfusion ratio in different parts of the lung in a normal person. Okay. Okay, in order, this is the values that we have already mentioned. Ventilation perfusion ratio, V is 4.2 per the pulmonary blood flow. That's the cardiac output is 5 liters. V by Q is 0.8. That's the normally that we see. Optimal ratio is about 1. Okay, the good ratio is 1. Okay. In addition to this concept, we also have one more concept over here that we need to understand, that the two circulation that is coming over here, the pulmonary circulation and the systemic circulation, the blood will mix up between them. Okay, this is called as the anastomosis. Okay, so the system, the bronchial artery brings the blood, and the bronchial vein and the azygous vein takes back the systemic circulation, and the pulmonary artery and the pulmonary veins supply the blood to the pulmonary, and then the pulmonary vein takes out the blood, and between them there are some anastomosis seen. Okay, this causes the mixing of the blood. Okay, and the consequence of this mixing of the blood is there is a small change in the partial pressure of oxygen from the alveolar to the arterial blood. Okay, so we will discuss about that difference in the partial pressure slightly later. Just to mention about the anastomosis between the systemic and the pulmonary circulation over here. So increased ventilation or increased capillary blood flow increases the gas exchange. Okay, so blood that is not completely oxygenated is called as the shunted blood. The physiological shunt is the deoxygenated blood from the alveoli plus the deoxygenated blood returning from the bronchi and the bronchioles, because of this anastomosis that we have discussed now. Okay, so now let us discuss about the ventilation ratio, perfusion ratio in different parts of the lung. Okay, so as I have already mentioned to you, there are big alveoli in the apex. Okay, so this is the big alveoli. Okay, the reason for this big alveoli is that when in a standing posture, what will happen? There will be more in negative intrapleural fluids over here. Okay, so it will be more negative over here, more negative intrapleural pressure. Intrapleural pressure will be more negative over here. Because of the more negative intrapleural pressure, the alveoli will be big. Okay, they will be bigger, and here you will see small alveoli in the base. Alveoli in the base. Because of the big alveoli, okay, because of the big alveoli, what happened? You have the blood vessels that is constricted over here. The blood vessels that we have discussed before, it becomes like have a risk for becoming zone 1 because of the bigger alveoli. The blood vessels are constricted over here. Now what happens to the compliance? Okay, the compliance, hope you remember the compliance that we have discussed before. Compliance. Okay, so as the alveoli is big, the compliance over here is less. Okay, less compliance because it's already big. The chance for becoming the expanding of that is less. Okay, whereas when it is small alveoli, you will have more compliance. Okay, so when the air is coming, the ventilation, what happens here? You have more ventilation. Okay, because there is more compliance, there will be more ventilation. So easy expandability, more compliance means easy. So the more ventilation, more air can come in over there. Here there will be less ventilation, and as you see, there is a big alveoli. Okay, and it is compressing the vessels. What happens to the perfusion, the Q, or the perfusion? The perfusion, that means the Q. Okay, because the alveoli is big and is compressing the blood vessels, the perfusion is also less over here, and here the alveoli is small, so the blood vessels are easy to flow. What will happen? There will be more perfusion over here. Okay, but see, from the apex to the base, so these are all things in the apex. This is in the apex and this is in the base of the lung. Okay, so if you see that if this is like decreasing and decreasing, this is increasing and increasing. If you see from here, say this is your the base of the lung, and this is the apex of the lung. Okay, so base have what? More ventilation. If I draw the ventilation line, sorry, it won't be like this, it will be like this. It will be base have more ventilation, okay, than the apex. Okay, more ventilation than the apex. But if I draw the perfusion line, the perfusion, if it goes like parallel like this, that means more perfusion here. This is for the perfusion, and this one is for the ventilation. This is for the ventilation. So if it goes parallel like this, that means the V by Q ratio is over here is equal to the V by Q ratio over here. But that is not seen like that. Instead, how do we see? We don't see like this. Instead, if you have, this is the ventilation from the base to the apex. Okay, more ventilation here and more less ventilation over here. So this is for the ventilation. Okay, the ventilation. And if I take the perfusion line, how does the perfusion? In the base there is more perfusion than the ventilation, so it will go like this. Okay, more perfusion than the ventilation. Okay, so that's why the V by Q ratio changes. Okay, the V by Q ratio, that's the one that we have discussed here before. See, the V by Q ratio. Okay, V by Q ratio. Here the perfusion is less, too less. Okay, perfusion. Okay, the perfusion is very much less compared to ventilation. Ventilation, both of them are less, but perfusion is more less than the ventilation. That's why what happens to the V by Q ratio? You have a more V by Q ratio, increased V by Q ratio. Whereas in the base, what happens to the V by Q ratio? There is a decrease in V by Q ratio because the perfusion is more than the ventilation. Okay, the perfusion is more than the ventilation. You can see the perfusion is more than the ventilation in the base. Okay, so this is your the perfusion. So the perfusion is more. Okay, Q is above the ventilation, the perfusion, whereas here the Q is less than the ventilation. Okay, so what you understand from over here, when the V by Q ratio in the apex, you can see over here the V by Q ratio is more, right? The V by Q ratio is more over here, increased V by Q ratio. When you have an increased V by Q ratio, what you create? You create dead space. You create a dead space over there. That means the blood that is coming over there is very less, so it is not taking the oxygen. Okay, so the alveoli will have more oxygen remaining over there, and this helps like aerobic bacteria like the TB bacteria to live in the apex. So aerobic bacteria live in the apex. They like the apex. Okay. So because in the apex there is more V by Q ratio, and that means there is very less perfusion. Because of the less perfusion, you are creating more dead space. That means when you create that the blood is not coming over there, the oxygen comes and stays over there, and this oxygen is used by the aerobic bacteria like TB bacteria to live over there. Okay, hope you understood this concept. Okay, and also not only this concept, like for example, if the alveoli, what happens to the ventilation perfusion ratio? Okay, if the alveoli is completely blocked in this scenario, if you block it completely over here, okay, so what happens to the V by Q? Okay, so here the V is 0 and perfusion is 5. Okay, whereas instead of this, if you have something like scenario where you have blocking your blood supply, so what happens to the V by Q ratio? In this case here it is like the 4.2 divided by 0. Okay, that means the perfusion is not coming over there. Okay, so what happens over here? Here it is equal to 0, here it is equal to infinity. Okay, so here the V by Q ratio is increasing. Okay, is more than 1. Okay, here the V by Q ratio is less than 1. Okay, so it is increasing and decreasing. So over here this scenario is called as what? You created a dead space. Created a dead space. Here the blood is coming and wasting, so the blood is getting shunted. Here we created a shunt, and here we created a dead space. Okay, so by looking at the V by Q ratios, you have to understand whether the shunt is being happening or a dead space is being happening over there. Okay, so the shunt versus the dead space. Okay, so another like graphical representation for you to understand over here is the partial pressure in the alveoli. Okay, so when you create a dead space like this, dead space is created by blocking the pulmonary embolism, the blood is blocked over there. So what happens to the PO2 over here? The PO2 will equal to the atmospheric PO2, which is like the after mixing with the water it becomes like 149. That means the PO2 is increasing, and there is no carbon dioxide coming through the blood to the alveoli. So what happens to the PCO2? It almost goes to zero. That means it is decreasing in the decreasing when you create dead space. And when you create a shunt, what happens to the PO2? PO2 is becoming equal to that of in the tissues, which is PO2 is 40, which is equal to the tissue level. Okay, that means you are decreasing the PO2. But PCO2, what is happening? There is no carbon dioxide going out, only the carbon dioxide is coming from the blood to the here. So what happens to the PCO2 in the alveoli here? It becomes equal to that of the tissues, which is equal to high. So if you create the shunt, you decrease the PO2 in the alveoli and you increase the PCO2 in the alveoli. When you create a dead space, what happens to the PO2? You increase the PO2 and decrease the PCO2, the alveolar. We write it with capital A, capital A. Okay, alveolar O2 will be increased and alveolar carbon dioxide will be decreased when you create. So this is normally referred to as the V by Q mismatch. Okay, so some conditions that often result in significant V by Q mismatch include severe obstruction like status asthmaticus. Status asthmaticus is like a continuous asthma for long duration, asthma for long duration. Status asthmaticus, cystic fibrosis, anaphylaxis, etc. Infection like a pneumonia, and then partial occlusion of an airway, mucus plug, foreign object, etc. All will cause like what? A V by Q mismatch. Okay. So we have been discussing about this partial pressure. So now let us discuss more about the partial pressure of the gases. Okay. So in order to understand what is the meaning of the word partial pressure, okay, partial pressure equal to concentration of the dissolved gas divided by the solubility coefficient. Better to say that like partial pressure is the pressure exerted by a specific percentage of the gas in that group of gases or a combination of gas. So atmosphere contains what? Nitrogen and oxygen. Okay, nitrogen is about like 80 percentage and the oxygen is about like 20 percentage. Okay, and so if the atmospheric pressure is 760, what happens? 600 is contributed by the nitrogen and around like 160 is contributed by the oxygen. Okay, but if you change this 760 by going to high altitude, say if you are going to high altitude and the atmospheric pressure is only 500 now, so the oxygen partial pressure will drop down to 100 because 20 percentage of 500 is only 100, whereas 80 percentage of 600 is now how much? Is around 400. So both of them is decreasing. Instead, if you go to a high pressure area like under the water or something like that, where the atmospheric pressure itself is 1000, so what happens? You don't change the percentage. Okay, the percentage remains the same. So 20 percentage of the 1000 is around like 200 and this is around 800. So you can see the partial pressure of oxygen is increased in this scenario. Okay, whereas when you go to high altitude, the partial pressure of oxygen decreases. So this is an important concept about the partial pressure of the gases. Okay, so partial pressure is one important concept that helps the diffusion of the gas through the fluids. Okay, so always it goes from high pressure to low pressure. So pressure difference or the pressure gradient, which is represented by the delta P, is very important for the diffusion to happen. So it is directly proportional to the diffusion. And the area of the membrane, okay, which is decreased in disease conditions like in emphysema. Even though the lung is expanding in the emphysema, the partial pressure, the surface area of the lung is decreasing because the septum is breaking, because the elastic fibers are being broken and the septum is breaking. So the alveoli, which was like this, will change to like big alveoli, but the surface area from here to here, the surface area is decreased over here in the emphysema. Okay, in the emphysema the surface area is decreased. So there is a direct proportionality. So what will happen to the diffusion? There will be decreased diffusion, whereas the thickness of the uh, diffusion membrane, the pulmonary membrane, that is the membranes that is present between the alveoli and the blood. Okay, that gives the thickness. Okay, in pulmonary fibrosis, what happens to that? Increases. Okay, so this is inversely proportional to diffusion. So when you increase this one, what will happen to diffusion? diffusion will be decreased. So in conditions like pulmonary fibrosis, what happens to the diffusion of the gases? That will be decreased, especially of the oxygen. Okay, so this factor over here, the solubility by root of molecular weight, this is a constant. Okay, so this is called as a diffusion coefficient. Okay, if you take the diffusion coefficient of oxygen as 1, carbon dioxide have how much? 20 times more diffusion coefficient than that of the oxygen, because of the solubility. The solubility in the lipids, the carbon dioxide solubility in the lipids is very high. Because of that factor, the carbon dioxide solubility is very high, and its diffusion coefficient is 20 times more than that of the oxygen. Carbon monoxide have less diffusion coefficient than the oxygen. The other thing is, you need not like memorize, but carbon dioxide have less diffusion coefficient than the oxygen. So it's not easy for the carbon dioxide to dissolve through the membranes. It is not easy for the carbon monoxide to get exchanged. So assuming that the diffusion coefficient of oxygen is 1, the relative diffusion coefficient for different gases of the respiratory importance are shown over here. That is for the carbon dioxide. So another important concept that you must remember is the partial pressure of gases in blood are determined by dissolved gas, okay, and not by the reacted gas. For example, HBO. Okay, when the oxygen is bound to the hemoglobin, that is not contributing towards the partial pressure. Okay, for example, reacted with water or hemoglobin is not contributing. So only the dissolved oxygen or the dissolved carbon dioxide contribute for the partial pressure. Okay, so now let us see, to understand the importance of the delta P, one question over here. Okay, so a 54-year-old female presents with severe and progressively worsening shortness of breath. She has had a chronic cough for 2 years that is productive of sputum. It waxes in veins but never really resolves. She reports a 50-pack year smoking history. 50-pack year smoking history. Vitals are normal. On physical examination, the patient is leaning forward in her seat and breathing with pursed lips. Okay, this is one of the important indication for the obstructive conditions. Okay, so there is a prolonged expiratory phase. Okay, because her expiration is very difficult, so she's trying to do like a prolonged expiration. So her legs are hyperresonant diffusely. Pulse oximetry shows an oxygen saturation of 90% on room air and 82% with exertion. Okay, X-ray shows hyperinflated lungs and a depressed diaphragm. Hyperinflated lungs, again showing obstructive lung disorders. Okay, so arterial blood gas shows carbon dioxide is very high. Okay, arterial blood, just now we have learned arterial carbon dioxide should be only about 40, so it is like coming to 70. Bicarbonate is high. Okay, and the pH is almost normal. The patient is diagnosed with COPD and prescribed supplemental oxygen. Okay, so now the question is asking you, this is giving you a vignette of an obstructive COPD condition. Okay, which of the following mechanism best explains benefit of oxygen supplementation in this patient? So what is the use of giving oxygen to this patient? So as you know, in emphysema or in COPD, what happens to the surface area? It is decreased. Because of the decrease in surface area, you have difficulty to diffuse. So how to increase this diffusion? By increasing the pressure gradient. So if you increase the oxygen in the alveoli, it becomes easy for the oxygen to dissolve into the blood. So that pressure gradient to be created. Okay, so let's see what improves diffusion of oxygen into the capillaries. Okay, good. Okay, so that may be the option. So it improves the diffusion of oxygen into the capillaries. Okay, so aids in smoking cessation? No, nothing. Enables more, yeah, this may be true, enables more rapidly unloading of carbon dioxide, but that is not the purpose of giving the, this is true, but this is not the purpose of giving the oxygen supplementation. In this case, you want more oxygen for the patient, you want the more oxygen to go into the patient. Okay, so displaces carbon dioxide to improve respiratory rate and work of breathing? No, nothing to do with that. Intra-alveolar oxygen free radical formation fights pathogens? No, that's not the reason. We don't, it's not anything with pathogen. Okay, so high oxygen can cause oxygen free radical, and this can cause damage to the pathogens, and not only to the pathogen, to our body also. So what happens over here? You improve the diffusion of the oxygen by, because you know this diffusion equation now. Diffusion is directly proportional to delta P. Okay, so diffusion is directly proportional to delta P. So in order to create delta P, that means the pressure gradient. So pressure in the alveolar should be more than the pressure in the blood vessel, in the pulmonary artery. Okay, the pressure in the pulmonary artery. So If you give the supplemental oxygen, this pressure will be more and there will be more diffusion happening. It will go easily from the alveoli to the blood. So in order to increase the oxygen availability, you can give supplemental oxygenation. So this is the correct answer choice. Okay, let's see more into the partial pressure of the gases. Okay, over here, just now we have discussed the percentage of approximately 80 percentage is nitrogen and approximately 21 percentage is oxygen, and accordingly, because of that, what happens, the atmospheric pressure have how much oxygen. We are not worried about the nitrogen over here, we are worried about the oxygen now. So in the atmosphere you have 159. Okay, but as it enters into the respiratory system, the trachea, the bronchus, the bronchioles, etc., have what, the humidification property. Okay, they add water vapors to, so in order to control the temperature, so that the air that is reaching to the lung should be of the equal temperature to that of our body. Okay, so humidification will reduce the oxygen content to 159, will be reduced to about 149. Okay, and now this air that is coming from the atmosphere is going into the alveolar air. Alveoli already contains the functional residual capacity. So you are mixing the tidal volume, which is around like 500 ml, to, you are mixing it to the functional residual capacity, which is around 2500 ml. Okay, so you are mixing this 500 ml into the 2500 ml. From this 2500 ml, already the oxygen has been taken out. So this is having 149 partial pressure of oxygen and is coming and mixing it with the, so what will happen to this, this will be reduced to around 104. Okay, so that's why in the alveolar air you have the partial pressure of oxygen is 104. Okay, so now, so this is your alveoli which is having 104, and on the way it is 149, and in the atmosphere it is 159. Okay, so 159 to 149 because of the water vapor, you added the water vapor, and here you are mixing it with the tidal volume is mixed with the functional residual capacity, it became 104, and the blood vessel is coming over here and taking the oxygen to go out from here. So now what happens to that over here, you can see the blood vessel that is coming over here, that is the pulmonary artery, which is nothing but the systemic vein is getting converted into pulmonary artery and then coming to the lung, which is bringing the blood that is having very low oxygen, that is the partial pressure of oxygen over here is 40, and this 40 is now coming over here and getting converted to 104. But by the time it comes out in the pulmonary vein and to the systemic artery, what happens, you have anastomosis. Okay, anastomosis, the bronchial and the systemic and the pulmonary veins are like anastomosis over here. So what happens to this partial pressure of oxygen, slightly drops, and also if you have the heart, in the heart you have the Thebasian veins. Okay, Thebasian veins, which is also reducing the oxygenation. So this, it will become around like 95 over here. So the partial pressure is dropped from here. So this is the arterial oxygen and this is the alveolar oxygen. Okay, PaO2. So this difference between 104 and this 95, alveolar oxygen minus arterial oxygen, this difference is referred to as the AA gradient. AA gradient. Okay, so approximately around 10. The value of the AA gradient is around 10. Okay, so it's a normal gradient. Okay, so now what happens over here, this 95 is going to the tissues, you can see over here the 95 is going to the tissues and giving the oxygen. In the tissues it is kept at a very low oxygen partial pressure around 23, it can go a maximum low to about 15. Okay, and this then takes the oxygen and then becomes 40 in the venous blood. This 40 is the one that is coming over here for the alveoli to get exchanged. Okay, so this is what happens. Now after you exchange over here and everything, what is happening to this 104, it has to breathe out, you need to breathe out this one. Okay, so the air that is going out from the alveoli, the air that is going out from the alveoli, okay, let's see the air that is going out from the alveoli. Okay, so when it was coming in, it was 159, it became 149, it become 104 over here, and in the artery it becomes 95, and by the time it comes back over here, it is becoming 40. Okay, now this air is going out. Okay, so the volume of air that is present over here is around 150 ml. Okay, and the volume of air that is present over here is 350. Okay, so if you are taking the first ml from here, first, like say 50 ml of volume air is taken, what will be the partial pressure? That will be equal to 149. Okay, but if you are taking this air out, the air that is coming out from here, that is 50 ml, what will be the partial pressure? 104. But when it is coming out, there will be mixing up happening over here. So this air will be a mix of these two values, 149 and 104. So the expired air, the partial pressure will be around 120. So this will show around 120. Okay, so this is graphically represented over here. So the first, like say approximately 100 ml, what will be the partial pressure? 149. And the last, like oxygen that is coming over here from the alveoli, what will be the partial pressure? 104 over here. Okay, so this is around like 104 that is present over here, and in the middle you can see about 120. Okay, in the middle you will see around 120. So this middle air will show partial pressure of 120. The first air that is coming out will be like the outside air, that is like 149. Then the middle will be approximately 120, and the alveolar air will be of 104. Okay, so that is what is being represented over here. Now let us see the same thing for carbon dioxide. Okay, let's see the same thing for the carbon dioxide. For the carbon dioxide, there is no concept of AA gradient. Okay, there is no concept of AA gradient for the carbon dioxide, because there is no mixing up of blood, does not change and causes an effect onto the carbon dioxide value. Okay, so now for the carbon dioxide in the atmosphere, it's almost zero. There is nothing carbon dioxide in the atmosphere, so humidification does not change it, it's also zero. There is no, but in the alveolar air it becomes 40. Okay, it becomes 40. So let's see how it is becoming 40. Okay, so here it's zero, it's coming to zero, and in the alveoli the carbon dioxide is given. Okay, so the blood that is coming over here, the blood that is coming over here is giving the carbon dioxide to the lung. So the blood that is coming over here, that is the pulmonary artery, the systemic veins, is systemic veins that is bringing carbon dioxide here, which is around 45. Okay, so the 45 is coming over here and giving the carbon dioxide, and then becoming what? 40. Okay, so this 40 is then going to the tissue. You can see this 40 is going to the tissue, and in the tissues is always a higher partial pressure, because carbon dioxide is being produced in the tissue. So there is a higher partial pressure of the carbon dioxide, and this carbon dioxide goes and the 40 changes to 45, and this 45 is the one that is coming to the tissue, from the tissues to the lung over here, and changing into 40. Okay, so now if you take the same image over here and look for, let's look it for the carbon dioxide. Okay, so this is your alveoli. Okay, so this is your alveoli, and the outside is 0, here it is 0, here it is 40. Okay, so here is you are having like around like 150 ml of the dead space over here, and this is the alveolar. Okay, if you measure the partial pressure of carbon dioxide over here, it will be 0. Okay, and if you measure the carbon dioxide partial pressure over here, it will be 40. But the mixed up over here, if you measure, it will be around 28, an average of these two. Okay, so that is what is shown over here, the expired air. Okay, the expired air, that is called as the our pico. Okay, partial pressure of expired carbon dioxide, which is approximately equal to 28. So that is what is being shown again in the graph over here in the bottom line. Okay, so in the air that is coming from the alveoli, how much it will be? It will be around 40 over here. Okay, in the middle it will be around 28 over here, and the first 100 ml that is coming out will be 0. The partial pressure of carbon dioxide will be 0 over here. Okay, so you can see over here now. Okay, so the air that is expired, the first air that is coming out from the alveoli, it will be 0, the partial pressure of oxygen. In the middle it is about like 28, and in the end, the last the volume of air that is coming from the deep inside from the alveoli will be around 40. The partial pressure will be around 40. So this is the various partial pressure of carbon dioxide in different parts of the body. Okay, you must be able to memorize these values. It's important for to understand the partial pressure of carbon dioxide and oxygen in different parts of the body, in different parts of the alveoli, lungs, etc. Okay. Okay, so with the concept of this AA gradient, okay, for the oxygen we have just now discussed the concept of the AA gradient. Okay, AA gradient. Okay, so let's discuss a question in order to understand what is the importance of this AA gradient. Okay, okay, so a 56-year-old female is seen for shortness of breath. She had progressive external dyspnea for the past 2 weeks. It is now so bad that she is short of breath at rest also. It is worse at night and with a reclining. She has also gained 15 pounds in 2 weeks and has noticed edema in her lower extremity. She has a history of heart failure. So that's the reason for the edema. Okay, and reduced ejection, and is non-compliant with her diuretic. Non-compliant means she is not taking the diuretics. Okay, so that's why the fluid is accumulating in her body. Her vital shows temperature, okay, blood pressure is okay, heart rate is okay, respiration rate is okay, saturation is okay, and physical exam shows jugular vein distension. Okay, the fluid is accumulating in the heart. That's why crackles in the lungs bilaterally. That means pulmonary edema is there. Severe bilateral pitting edema. There is a great certainty fluid in her alveoli. That means there is pulmonary edema. So which of the following changes would be expected in this patient's lung? Okay, so what will happen to cardiac output? What will happen to the oxygen delivery? What happens to the AA gradient? Okay, so what happens to cardiac output? The question itself is giving there is a ejection fraction is decreased to 35%. That means it is decreased. Okay, that's correct. Oxygen delivery, of course, because of the pulmonary edema, can we exchange the gases? No, because the alveoli is like this, and there is fluid over here and fluid over here. So the blood vessels over here, the diffusion of the oxygen becomes difficult because the membrane is too much and the fluids are accumulating over here, so diffusion becomes less, so oxygen delivery is decreased. Okay, that's also correct. What happens to the AA gradient? Okay, so the oxygen that is coming up to here, okay, that is the atmosphere. Do we have any problem in the atmosphere here now? No, in the atmosphere the partial pressure is 159. Okay, it becomes humidified, it becomes 149, it comes over here, it becomes 104, but it is unable to give the oxygen over here. So what happens to the saturation over here? It may reduce to say, let's say 80%. It may be reducing because there is no exchange happening. So what happens to this gradient between these two, the PaO2 and P small a, that is the arterial O2. So this gradient will be increased. So this gradient will be increased. So this is your answer choice. Okay, so the AA gradient will be increased in disease conditions like cardiovascular conditions, in lung condition like emphysema, fibrosis, etc., and cardiovascular condition, anything that's condition related to the body. But AA gradient will not be increased, but the arterial oxygen will be decreased if you go to high altitude. When you go to high altitude, in the high altitude, what happens? The say the nitrogen and oxygen, you remember this one, 80 percentage and oxygen is 20 percentage. So in a normal atmospheric pressure, this is like 159, right? The oxygen contribution, oxygen P atmospheric oxygen is 159. Okay, 159. Okay, but what happens if the atmospheric pressure, if you go to high altitude, it becomes 500. So the 20 percentage of the 500 is only 100. Okay, so what happens to the alveolar? That is also dropped. So the alveolar oxygen will be dropped. So because of that drop, what will happen to the arterial oxygen? Arterial oxygen will be also dropped. But the difference between these two, that is the AA gradient, will be normal. Okay, so a drop in arterial oxygen with normal AA gradient indicates a problem in the atmospheric oxygen, or there is lack of oxygen coming into the lungs. Okay, so that's the meaning when there is an increase normal AA gradient with decreased PaO2. But decreased PaO2 with increased AA gradient means there is a problem in the lung, or like a pulmonary edema, pulmonary fibrosis, emphysema, or a cardiac problem. The blood is unable to come over there and take the oxygen. Okay, all this will tell you about the an increased AA gradient. So that's the question trying to ask you about the AA gradient. Okay, so another concept that we want to discuss is about the diffusion limited versus perfusion limited gases. Okay, so remember over here, all the gases in our body is perfusion limited. That means if there is an alveoli and the blood is not coming over there, we cannot exchange that gas. Okay, that means it is perfusion limited. If there is a limitation to the perfusion, that gas is not able to go there. Perfusion limited, otherwise also called as the flow limited. So all the gases including carbon dioxide, oxygen, nitrous oxide, any carbon monoxide, everything is perfusion limited. If the blood is not coming there, there is no exchange of that gases. Okay, but there are some gases which are diffusion limited. The most important gas that is like always diffusion limited is carbon monoxide. Carbon monoxide is always diffusion limited because it cannot exchange, because its diffusion capacity is very low. Not only that, its affinity for the hemoglobin is very high. So as soon as it goes into the body, into the blood, it reacts with the hemoglobin, and the reacted gases is not considered for calculating the partial pressure of the gases. Okay, so let's see over here. So whether or not substance passing from the alveoli to the capillary, blood reaching equilibrium in around 0.8 seconds, that is the cardiac cycle duration. So that blood takes to traverse the pulmonary capillaries at rest depend on the reaction with the substances in the blood. So thus, for example, the anesthetic gas nitrous oxide does not react and reaches equilibrium, does not react, so it does not react with anything in the blood, so it reaches equilibrium in about just 0.1 seconds, where you have around zero point 0.8 seconds. So this is around 0.8 seconds duration, right? Okay, that's the cardiac cycle duration, you have the time. So nitrous oxide like just requires like about 0.1 seconds in duration, it reaches to the equilibrium with the alveolar level. Okay, so in this situation, the amount of nitrous oxide taken up is not limited by diffusion, but by the amount of blood flowing through the pulmonary capillary. Thus, it is a flow limited or a perfusion limited gas. Okay, so on the other hand, carbon monoxide, okay, carbon monoxide is taken up by hemoglobin in the RBC at such a high rate that the partial pressure of carbon monoxide in the capillary stays very low, and equilibrium is not reached even in 0.8 seconds. The blood is in the pulmonary capillary. So therefore, the transfer of carbon monoxide is not limited by perfusion at rest, and instead is diffusion limited. Okay, so carbon monoxide is never reaching to this value. Okay, it's never reaching to the alveolar level. So that is, carbon monoxide is always diffusion limited. So oxygen is in intermediate between. Okay, it takes about like approximately around like 0.3 seconds to get equilibrium. So either if you reduce this 0.8 seconds to right around like 0.3 seconds, if the cardiac cycle duration is not 0.3 0.8 seconds, if it is reduced to around 0.3 seconds, there is no sufficient time for the oxygen to get equilibrated. So it may not reach the equilibrium, that means the equal between the alveoli and the blood, it may not reach. So what will happen? The oxygen will become diffusion limited in that scenario. So for example, if your blood flow is less, that is perfusion limited. If you have like a emphysema or fibrosis, etc., and it becomes difficult for the oxygen to perfuse through, then what will happen? It becomes diffusion, it becomes difficult for the oxygen to diffuse through the membranes, so it becomes diffusion limited in that scenario. So oxygen is intermediate between nitrous oxide and carbon monoxide. It is taken up by hemoglobin but much less avidly than carbon monoxide, and it reaches equilibrium with capillary blood and in about like 0.3 seconds. Thus its uptake is perfusion limited in a normal scenario, and only in disease conditions the oxygen can become diffusion limited. Okay, normally it is not diffusion limited because only 0.3 seconds is required and you have 0.8 seconds, so it is not diffusion limited in a normal person. So carbon dioxide is perfusion limited. So carbon dioxide retention is rarely a problem in patients with alveolar fibrosis, even when the reduction in diffusing capacity for oxygen is severe. So oxygen become diffusion limited in exercise, severe exercise, emphysema, fibrosis, etc. And there will be increased AA gradient. That's what we have seen just now in this question, right? There will be increased AA gradient for oxygen may occur in hypoxemia. Causes include shunting, V/Q mismatch, fibrosis, etc. Okay.